Hello and welcome again. Today we have a very good friend of mine and a special guest. Dr. Schwartz has been in private practice at Piedmont Physical Medicine and Rehabilitation. He has been the medical director of physical medicine and rehabilitation at Bonn Seacourse, St. Francis Hospital System in Greenville, South Carolina since 1984. He attended medical school at Wayne State University in Detroit, Michigan, and completed his residency in physical medicine and rehabilitation at the University of Texas Health Science Center in San Antonio, Texas. Dr. Schwartz is a board certified in physical medicine and rehabilitation, pain management, electrodiagnostic medicine, orthopedic medicine, and medical thermology. He's also a fellow of the Society of Vascular Medicine. Dr. Schwartz is a chairman of the board of the American Academy of Thermology, AAT. He has lectured extensively throughout the United States, Europe, Latin America, and Asia, and has a long list of distinguished publications, including his book titled Resolving Complex Pain. Dr. Schwartz has a long and extensive background in dysautonomia, CRPS, RSD, and medical thermology. He founded the South Carolina Reflex Sympathetic Dystrophy Support Group in 1986, which received national recognition from the Reflex Sympathetic Dystrophy Association of America. He has sponsored or contributed to annual internationally attended dysautonomia and CRPS RSD symposiums for 35 years. Dr. Schwartz is the editor for each of the American Academy of Thermologists' medical thermology practice guidelines. These guidelines were first published in 2006 and are revised every 3 years. He is the lead instructor for the American Academy of Thermology online member certification courses and for the AAT physician interpretation course. Wow.
Yeah, really. That was pretty impressive. Thank you for that introduction.
So let me start with asking you, how did you get involved with thermography?
It's really kind of an interesting story. I'm not exactly sure you just fall into these things. When I got out of residency, I was always dedicated towards finding how to treat complex chronic pain syndromes and to finding alternative ways of doing that that would avoid surgery or that would look into the root cause of pain. And started out, nobody even believed this thing called RSD or CRPS existed, but I was seeing it. And you can't be, in my mind, a true scientist or truly trying to help people if you're not willing to look at what their chief complaints are or what their issues are. And clearly one of them is weather sensitivity. So I started out in the days of liquid crystal thermography, just studying to see if I could see if there was in fact or changes in the skin physiology that would allow us to evaluate the autonomic nervous system that we have no other tools to use.
Mm. I think we have a little bit of a lag time between your audio and your video, but I'm always interested in what you have to say. You've opened up a whole new kind of aspect for me, even though I've been involved with thermography like you for many, many years. You coined a phrase that I keep repeating to other thermologists as well as some patients, that thermography is simply an extension of your physical exam. Can you elaborate on that?
Yeah, so I mean, I didn't really coin that phrase. It started with training for electrodiagnostic medicines for EMGs and nerve conduction studies. And that's for the normal sensory nerve that makes you move. Whereas sympathetic skin response studies with mapping under thermography is for the sympathetic nervous system. You can't really assess these things with a physical exam. You need additional information, not unlike I might need a stethoscope to listen to your heart. The stethoscope is an extension. An electrodiagnostic study is an extension of your physical exam because it helps you define exactly what motor or sensory nerve roots might be involved, or pinched nerve in your neck, or thoracic outlet syndrome. Whereas thermal imaging, medical thermology, is an extension of the physical exam, not only for the sympathetic, but it makes you cross-discipline your thinking. It makes you think about the vascular system, the neuromusculoskeletal system, and using that sympathetic system as a bridge. So there, you get findings and information that you simply physical exam alone.
Mm-hmm. Let me ask you, because maybe some people are not familiar with the term RSD, regional sympathetic dystrophy. Can you explain what it is?
Yeah, so it's commonly called complex regional pain syndrome today, but for hundreds of years it's been called reflex sympathetic dystrophy. And even though CRPS is a name today, the names have changed over time, and the only one that's been persistent is RSD. So I guess have been around too long to change it. And quite frankly, not all complex regional pain syndromes are RSD. But think of it like by reflex, kind of like a knee jerk. The sympathetic system becomes abnormal. So there's an event, something occurs, and the sympathetic system. So there's lots. Most people say, well, I don't even pain might be. Well, most people have sprained their ankle, and they know when they sprained their ankle or they had some kind of ligament strain that at first they get this sharp pain, and that sharp pain tells them that there's something wrong. Well, that's the sensory nerve telling you there's something wrong. It's a fast fiber, we call it. It's not a motor nerve that makes you move. It's not something that you feel. But then it starts to burn, and it starts to ache. So the question becomes, why do you even know that that's there? Well, that's the sympathetic nerve. That nerve monitors other injury sites. It works in the system. It doesn't become dystrophic or abnormal unless it fails to shut down. And sometimes not only does it not shut down, but becomes overly excessive in its response. We call that a reflex meaning it occurred as a result of an event. Sympathetic, it's the sympathetic nerve that's involved, dystrophy. So think about it like a car engine that's backfiring. I grew up in Detroit, so I still use a lot of car analogies. And so this car is just backfiring. It's not firing properly. Or it's not so true today, but in the days when you only had manual keys, you're nowhere near your car and it's still knocking, it's still dieseling, it won't shut off. Mm-hmm. So in the case of dystrophy, even though the injury is old or the event is old, your body should have gotten over it already, you still carry it with you. It's not letting go. We call it reflex sympathetic dystrophy. That's the physiology, the actual medical changes that's going on, of course, are even more detailed. But to the patient, to the person that's afflicted, all they know is that the example is getting cold. It's always cold. They don't want anything to touch it. They don't like it when the weather changes. And what used to be just a normal stimulus becomes a painful stimulus. Maybe it's sweating, maybe it's swelling, it starts to tremor, it can turn colors. In even more severe cases, they can even lose their skin and their muscle. I've seen cases where it looks like saran wrap on top of bone. They get so much.
So where does thermography come in? Can you explain how you use thermography in your physical examination of these patients?
Sure. So let me just elaborate a little bit more. So when the sympathetic system occurs automatically. It works by itself. It's independent. You don't tell your eyes to dilate when it's dark out. You don't tell your heart to beat. You don't tell your bladder to empty. You don't tell you when it's time. These are things that just occur automatically. For example, when it's really humid out, your fingers swell. You don't tell them to do that. When it's really cold, they constrict. You don't tell them all of a sudden your ring gets loose to do that. It happens automatically. These things are controlled by the sympathetic nervous system. They're regulated both outside the spine in your body and also in certain centers in the brain stem. So one way that we can get a look into this is to put you into a cold stress environment. So we would disrobe you and we would put you into a room that's cold and we would leave you there and image you. At 15-minute intervals, we image you. And by measuring you with what's called infrared imaging, the spectrum of wavelength that measures heat and temperature that we don't see with our eyes, we're able to create a picture of where the heat is generated in the body. So you don't expect to take a hot glass of water and put it in the refrigerator, walk back in the next day or a few hours and have one half of the glass hot and the other half cold. You expect it to equilibrate. We expect your body to do the same thing. And if it doesn't do that under this imaging test, then we know that there's something wrong with your sympathetic system. It's not regulating itself properly.
Mm-hmm. Interesting. So let me ask you, because you have been involved with setting up standards for AAT, which are accepted internationally by many thermology associations. Why is it important to have standards in thermology or in medical thermal imaging?
Well, like anything else, if you don't do something within proper guidelines or within proper parameters, you don't really know what you're looking at. So if you were to say we're going to evaluate a football game and we're going to just randomly pick snapshots of time in the football game and to tell you what happened in the game, well, you're going to be wrong. You'd have no idea. So everybody has to be looking at the game in the same way by the same rules. So in particular with thermal imaging, it's important because you don't want to be measuring, for example, the external environment. You want to make sure that the room that you're equilibrating in, or that the temperature of the refrigerator, as we spoke earlier, is constant. Well, it may not equilibrate if we make the temperature 90 degrees 1 minute and 10 degrees the next and all over the place. We can't get it so where your body has a chance to settle down and equilibrate. So we have to control the environment. We have to control the views that are taken, the images that are seen. Infrared cameras are not like a regular camera. If you don't look at it directly straight forward, you lose focus. And so if you aren't looking at something with proper focus, then you're not even seeing accurate information. And what we call protocols, in order to what I like to teach called vasomotor mapping, to see the distribution or the findings of abnormality, you have to make sure that everything is properly imaged to begin with. So those are just a few of the factors. Naturally, we have several days of courses that we go on, but you have to obtain the information properly. The person doing the test has to be properly trained, and that way you know that if there's an abnormality in the test that you're actually looking at the patient, not the other factors.
Right. So speaking about full body imaging, what can you say about that? Like, what sort of things can we find out from medical investigation in terms of full body imaging?
Well, speaking both for myself and the American Academy of Thermology on this question, so we have guidelines for neuromusculoskeletal imaging, for breast imaging, for what we call oral systemic, which is what would encompass our full body options, and then veterinarian applications as well. There are certain things called thermal signatures. When you see it can really mean a certain condition is present. These signatures are mostly reliable and known and described for neuromusculoskeletal. They're risk factors or a constellation or a cluster of findings that we call TH1 scores in breast. And when those numbers become higher, we say, but they're not diagnostic for a specific condition. You have to proceed what that means. When it comes to whole body imaging, they're just pieces of information that helps you look at maybe something suspicious. Maybe there's wiser and isolated area of heat, for example. One case comes to mind where I had a gentleman that had traveled quite far to see walking. He was on a walker. Every test and convention done, and he just wasn't getting any better. He would travel for me to do our assessments. We did all the traditional things we were doing, and frankly, we just weren't helping him. So we got thermal imaging. We didn't do a whole body study, but we did a lower extremity study, and in that evaluation, we got his torso as well. And we noticed that he had increased warmth in the left leg. And well, why would that be there? I mean, there's no reason for that. So he ended up getting a CT scan of his abdomen and found an aneurysm. So that whenever he stood up, the aneurysm was getting compressed and it was making, and all of our peripheral studies had missed it. So in this case, the thermal imaging made me think of something different. It made me look at this differently. It made me decide there's something going on here I need to investigate further. There are several factors where whole body thermal imaging can play a role. However, the AAT guidelines are very specific about what they are and very specific about how to do the studies and when they're applied. In general, the AAT does not support doing a whole body study as a diagnostic tool. It maybe could be a screening application that might help you look further, but it's okay to do the study. You just need to make sure that if somebody's receiving it or paying for the study, that they realize it's a different kind of tool to assess whether or not there's any index.
Sorry, can you repeat the last sentence? We lost your audio.
So if you're going to do a whole body study, then and this is different than a neuromusculoskeletal or breast or a veterinarian study. If you're going to just basically image the whole body and use what we'd call a wide sweeping, we want you to just to inform your clients that this is not a diagnostic assessment. This is just an assessment that's trying to give us a is it may be suspicious or may not. And if it shows something, it may require further investigation or may not. And if it doesn't show anything, it doesn't mean there's nothing there either. It's just another way of looking at physiology.
Right. Yeah, I always kind of warn people that come to see me saying that I'm just giving you kind of a sense of direction where else you need to investigate. I'm not saying that there is something there, because I can't. I'm just looking at the surface of your skin. However, if I see something that I think is suspicious, I'm just telling you, investigate this area or investigate that area. It may be something that needs further investigation, right?
Yeah, and so that's really a great way of putting it. And you know, it also is a segue into this concept that for most conditions, thermography is an adjunctive or a collaborative or an additional study. So maybe the person that's getting this study has failed conventional medicine in terms of getting a diagnosis, and so they're looking for anything that might give them some clues. That doesn't mean that when you did the study that you don't need elsewhere. Like you said, you do. Mm-hmm. Like I said, with the exception of neuromusculoskeletal, there's very few conditions that have definitive thermal signatures. The rest of them are just giving you your clinician or your healthcare provider and yourself a different way of looking at what might be going on so you can investigate differently.
What I also like about thermography is because you can use this, there's no harm or radiation, that you can use this technology to track their therapy or the progress, or whether they're getting better or whether they're getting worse. What do you think about that as a prognostic indicator?
So there's certainly a role for, and I see that the video has gone out, by the way. I think that's just the.
And now the audio is gone. So I hope you can rejoin us soon. You there? Here we go. Welcome back.
Yeah. So, yeah, the question is whether or not there's a role for. Certainly in the case of certain neuromusculoskeletal conditions, there clearly are. Intervention that you did, such as a sympathetic ganglion block, or to see if there's been a spread or a progression of sympathetic component, or new indications for this in neuromusculoskeletal. In the case of breast, there are also indications because you're trying to measure. Maybe you have a normal study. Maybe it's a year later, you're doing another study just to see if there's any surveillance changes. And now it's not really abnormal, but it's not as normal as it was before. Well, it becomes a little bit suspicious to you. So changes in physiology over time are more easily picked up. Having said that, if you have a normal study, there's no 6 weeks or 3 months, because if it's normal, it's normal. The most common case that you would do a surveillance over time, even if it was normal, would be breast, because you're looking for risk factors. And that's no different than measuring blood pressure. Your blood pressure, you go for your annual, you come back in a year later and it's a little elevated, and the doctor says, let's just measure your pressure at home for, daily on your own, keep a log, and I'll see you in another 2 months or whatever, and we'll check it again. And the pressure keeps trending upwards. Okay, now he's getting worried because you have some serial findings in that regard. Whenever you measure physiology, serial evaluations can have a role.
Yeah, I like that analogy too. Anyway, I apologize to everyone who is watching this, because we've seemed to have a lot of audio as well as video lapses. But as I said, you always have something interesting to say. That's why I continue with this interview. Where do you see thermography kind of go in the future? What's the course? Where do you see it 5 years from now, 10 years from now?
I really think that medical thermal imaging in particular is at a crossroads. We at the American Academy of Thermology, we talk about the difference between scientific medical thermology and everything else. In order for scientific medical thermology to progress and for the medical community to accept thermal imaging, I really do think we're at a point where we need to improve our digitalization and our artificial intelligence data extraction. This is happening in the radiology community. Many veins right now. Thermal imaging, we're just really talking about doing that. As this becomes more objective and less subjective, as you start having deep computer learning help us, imaging is, you're just looking at temperature. In fact, you're looking at lots of information. It crosses multiple disciplines. One of the problems with it is that there's a lot going on. It's actually difficult to be well trained in how to interpret and even report your findings. So as we get rid of those problems, as we improve on those problems with artificial intelligence, if we're successful in that, I think that thermal imaging, in particular in medical applications, awesome. And that's going to be over the next 3 to 5 years. Hopefully not quite that long. On the other side of it, if we fail at that and medical thermology or just thermal imaging remains on a one-on-one basis with individual practitioners and sometimes medical not, I think it's not going to die on the vine, but it's certainly not going to grow. There's always going to be a niche for the neuromusculoskeletal conditions because there's no other way for them to be evaluated. But truthfully, there's very few practitioners, nationwide and worldwide that specialize in those disorders, because dysautonomias are still relatively new to medicine in terms of how we approach them and treat them. So we're excited at the AAT. We're helping promote and promulgate the use of scientific medical thermology and artificial intelligence applications. So we're quite hopeful that over the next 3 to 5 years that it will grow in prominence and acceptance within the medical community.
That's great. Listen, thank you for taking the time. I really appreciate that. I'm always kind of fascinated with what you have to say. Once again, I apologize to everyone who just had a bad connection today, but it's better to have a few words missing but you've given a very good kind of overview about thermology and something for many people to ponder about referred pain or regional sympathetic dystrophy, the old term or the new term. There's a lot of people who are very, very uncomfortable in pain and hardly getting the treatments that they need. Thank you again for being here, for being a guest. I hope to interview you again, maybe when we have a better connection someday. Would you do that?
Oh, absolutely. I'd be delighted. And thank you for all you do.
Thank you. Okay.
Take care. Bye-bye.